Thank you very much for the invitation to speak at this conference. My name is Daryl Jones, and I'm going to be talking about in-hospital cardiac arrests in Australia. So I'm going to go through the background to this study and the aims of the study, the inclusion and the exclusion criteria for the study, the results discussion and summary, and if I have time, talk about the governance and the oversight. This has recently been published in late last year in the journal Critical Care Resuscitation. So the background to this study was that existing data on in-hospital cardiac arrests in Australia was of quite poor quality. The frequency of reported in-hospital cardiac arrests varied quite widely, from 0.58 to 6.11 per thousand admissions, depending on the study design and the population. Only 10 studies had reported the initial rhythm, and in approximately a third of those, the rhythm was thought to be shockable. In only 46%, return of spontaneous circulation occurred, and 3/4 approximately died within hospital. So the aim of this study was to conduct a prospective observational study to evaluate the epidemiology of ward-based in-hospital cardiac arrests in the context of rapid response teams. We aim to look at the frequency of the events and the patient demographics, the timing and initial rhythm associated with the cardiac arrest, the management both within the cardiac arrest and on the ward, and then the hospital discharge status. This was a prospective observational study involving 7 hospitals in Australia over approximately 1 year period, and it included adult patients aged over 18 years who were by definition unresponsive, had no respiratory effort, and had commencement of external cardiac compressions. Exclusion criteria included those who had a previously documented, not for resuscitation order. This had to be documented in the patient file. They had also excluded if they'd received cardioversion but no external cardiac compression, example for atrial fibrillation or conscious VT. And we also excluded in hospital cardiac arrests in non-ward areas such as the ICU, ED, operating room, or cardiac catheter laboratory. So the study went for approximately 1 year, although the inclusion period varied according to the hospital site. The median inclusion was approximately 9 months. This was a very large study, enrolling 472,000 admissions with a median of 75,000 per hospital and 185,000 multi-stay admissions with 22,000 median in each hospital. There were nearly 16,000 rapid response team calls with a median of 2,200 per year. There were 159 cardiac arrest events with a median of 18 per year. And that meant that there were only 2.2 events per month in each hospital with a rate of 0.27 per thousand total admissions or 0.62 per multi-day admissions. What we found was that there were 159 events occurring in 152 patients. Return of spontaneous circulation occurred in approximately 2/3, and in approximately half of all the in-hospital arrests, the patient was admitted to the intensive care unit. So this was the immediate outcome of the patient. In terms of the timing of the event, approximately half of the cardiac arrests occurred in the first 4 days. So that means the median time for onset was 4 days, but you can see that 1/4 of them occurred beyond 12 days, and approximately half of them occurred within business hours, as is shown by the histogram on the right-hand side. The patient demographics were similar to that of previous studies, with approximately 2/3 being male and the median age being approximately 72 years. 2/3 of the patients were admitted under a medical as opposed to a surgical bed card. Cardiovascular disease and risk factors were common in the prior to hospital admission. However, only 42% of patients had an admission diagnosis that was related to a cardiovascular problem. And you can see that gastrointestinal, neurological and respiratory complaints form the basis of the system associated with the admission diagnosis. The vast majority were for full care, so they did not have any pre-existing documented limitations of care, and the vast majority were also from home, as opposed to some sort of a supported accommodation or a nursing home. We found that 2/3 of the initial rhythms were not shockable, i.e. asystole and pulseless electrical activity. And although 3/4 were witnessed, only approximately 43% were monitored with continuous ECG monitoring or telemetry. Adrenaline was used in approximately 2/3, and amiodarone and atropine were each used in approximately 1/7 of cases, and consistent with the fact that only approximately 1/3 of the rhythms were shockable, only 1/3 of patients received defibrillation. The median duration of cardiopulmonary resuscitation was 6.5 minutes, but 1/4 of patients received more than 18 minutes of CPR. And in approximately 1/5, the duration of CPR was actually less than 2 minutes. This table shows the intensity of management within the intensive care unit. 4/5 of patients received noradrenaline, approximately 1/3 received adrenaline, and these were often for extended periods. So 41 hours for noradrenaline, median time 10 hours for adrenaline. 1/7 received milrinone or dobutamine, and 1 in 10 patients received ECMO. 4/5 of the patients received ventilation either invasively or non-invasively, and 1/3 received renal replacement therapy. The in-hospital outcomes of these patients were relatively favourable compared to previous studies. Approximately 40% survived to hospital discharge, and approximately 25% of patients, approximately 1/4, went home. So what we found that in Australia, in these 7 hospitals with mature rapid response systems, the events are relatively infrequent and they are mostly non-shockable. And this has now stimulated discussion in Australian hospitals with mature rapid response systems about having a tiered approach to advanced cardiac life support training, where only expert responders are trained extensively in the elements of ACLS. And we are increasingly thinking that perhaps it's a better investment to teach junior medical staff and nurses on the ward in how to prevent cardiac arrests. We think we'll get a lot more return on our investment. However, although they're relatively infrequent on an individual hospital basis, when you look at Australia-wide, there are still approximately 2,800 events per year, resulting in approximately 1,700 deaths per year. And this is several-fold higher than our road toll, for example. The outcomes we've reported are considerably better than those previously reported, and we believe that this is mostly due to the fact that many were witnessed, and also many had a very short duration of cardiopulmonary resuscitation, and this may relate in part to the fact that new guidelines within Australia suggest not to check for a pulse before commencing CPR. So the suggestion for commencing cardiopulmonary resuscitation is the absence of signs of life and the absence of respiratory effort. So in summary, in Australia, in the 7 hospitals studied, in-hospital cardiac arrests are relatively uncommon, occurring approximately once a fortnight in each hospital. Most of the patients who suffer a cardiac arrest come from home and are functionally independent prior to having the event. Although cardiovascular disease is common chronically, only 40% of patients were admitted with a condition that is related to the cardiovascular system. 2/3 of patients were male, 2/3 were admitted under a medical unit, 2/3 had a non-shockable rhythm, and 2/3 received adrenaline, and 2/3 obtained return of spontaneous circulation. Approximately half of all the cardiac arrests occur in the first 4 days, approximately half business hours. In addition, a half are admitted to ICU, where most patients got noradrenaline and ventilation, and about 10% of patients received extracorporeal membrane oxygenation. The survival rate was 40% to hospital discharge, and approximately 2/3 of survivors were discharged home. And just a bit about the governance and oversight. This is the management and the writing committee. We use standardized case report forms and encrypted transfer of de-identified data with prospective statistical analysis plans, and these are the site investigators. Thank you once again for the invitation to present.